All right. Hello, Dr. James Griffin. My pleasure to introduce the fifth and final session of the day, Advocacy and Political Involvement. We're honored to be joined today by Dr. David Klingensmith and Tanya Schnell. David Klingensmith, DO, FAOCA, MBA, graduated from UHS-COM, completed his training in anesthesiology at Penn State University's Hershey Medical Center in 1998. He served in the U.S. Army for 8 years, first in Heidelberg, Germany, then in Beaumont Army Medical Center in El Paso, Texas. Upon leaving the Army, he took a position in a small practice of 12 anesthesiologists at Kalispell Regional Medical Center in Kalispell, Montana. He later joined a large group in Las Vegas where he served as chair of the CQI committee and on the Clinical Governance Board. As a fellow of the AOCA, he currently serves as chair of the Advocacy Committee and is a liaison with the ASA. He'll be speaking on state of legislation concerning certified anesthetist assistants. Please join me in welcoming Dr. Klingensmith.
This first part of this presentation won't take very long, but I do want to take the opportunity to just briefly discuss certified anesthesiologist assistants and the current status of the legislation concerning them. I have no disclosures, objectives really just to help us to more be aware of the existence of these healthcare professionals that are at our disposals and that are contributing greatly to the anesthesia team. So certified anesthesiologist assistants, until a few years ago I hadn't even heard the term, but they have been around since the 1960s, and they are licensed and credentialed healthcare professionals. They have successfully completed an accredited master's degree program, and successful applicants to the program have completed a pre-medical coursework, pretty much equivalent to a pre-med degree, and they're trained to completely participate in the care of the patient from the preoperative assessment all the way through the intraoperative and the postoperative care. They help balance and supplement the anesthesia workforce, and hopefully the goal is obviously through the care team to decrease costs and increase quality. So as far as the background, they started in 1969 was the first training program that was began accepting students, and that was in Emory University in Atlanta. Subsequently, at Case Western Reserve and University in Cleveland, there's currently about 3,000 in the United States, and there's now 21 training programs. And their state licensure is expanding, as you can imagine, since many of you maybe haven't heard of them. They're not in all 50 states yet. Because of the potential that they have to expand the anesthesia care that we need in this country, the ASA has adopted a very aggressive policy to assist them in gaining licensure in all states. There is an American Academy of Anesthesiologist Assistants that is, we'll talk about in just a minute, and the ASA is providing great support and help to them in accomplishing their goals. As far as the question, just get it out there out front. Is there any difference in the safety, the care, the quality of care administered by AAs or anesthesiologist assistants compared to CRNAs? And a study was done in 2018 that showed that surgical outcomes and were no different. Again, these are studies that are often fraught, as we heard earlier, with trying to prove that one's better than the other. It's much simpler to declare that there's at least an equivalency there. So The one thing that's unique about CAs versus CRNAs is they are licensed and credentialed to work specifically within the anesthesia care team, as described by the ASA. And that care team consists of a supervising anesthesiologist, physician anesthesiologist, supervising 1 to 4 mix of CRNA or CA. So as I mentioned, their scope of practice is limited to that supervision. They do undergo rigorous education. They do the pre-med baccalaureate training, and then they enter into this master's degree program, which is 24 to 28 months in length. These programs are all housed within universities, typically with schools of medicine, and these applicants have to have a bachelor's degree, completed that pre-med coursework, and then scored competitively on the MCAT. So these programs are all have been accredited by a national accreditation society that does accreditation for 23 different healthcare professional programs. They have to pass that certification examination. It's administered by the National Commission for Certification of Anesthesiology Assistants in collaboration with the National Board of Medical Examiners. And this is what's unique and is integral to their success, I believe, is the fact that they are under the auspices of the National Board of Orthopedic Medical Examiners, and that lends great credibility to their training and their education. And then they have a CME requirement of 50 hours a year. So as I mentioned, there is this academy, American Academy of Anesthesiology Assistants, whose mission is to support and advocate for the anesthesiology assistants around the country. And their goal is to establish and maintain the standards of admission by fostering and encouraging continuing education and research to all graduate anesthesiology assistants and enrolled students of accredited programs. So again, important to emphasize, they are clinically interchangeable, if you want to use that terminology. They are as safe and effective as nurse anesthetists. There's no credible evidence of any sort that the care provided by the anesthesiologist assistants is less safe. And it is the position of the ASA that both CAs and nurse anesthetists have identical patient care responsibilities and technical capabilities. So currently, as you may realize from the discussions we've had on advocacy, so much of what is accomplished within the United States happens at the state level, and this is it is a state by state evaluation of their status. And at current, there are 21 states and the District of Columbia that authorize a practice. 17 of them in DC are licensure, and the others are delegatory authority, the other 4. And there's currently 8 states that have legislation under consideration, and the ASA and the AANA are working together aggressively to try and get these passed. In Nevada, we just, in May, I believe, was when the governor signed into law allowing anesthesiology assistants to practice in Nevada. And in our practice in Las Vegas, we have hired 2 who started a week ago. There's 21 different programs right now around the country. So as I mentioned, there's 3,000 currently, but we can anticipate, I think, that number is going to grow and begin to grow rapidly. And so I think it's very important that the ASA has taken a leading role in assisting that progress. The, um, the one thing I did want to mention, we've been talking about PACs up here and how important these political action committees are. I was just looking today, and I looked at the AANA's PAC website, and they have a graphic bragging how 18 states anesthesiologist assistant bills had been introduced, and that they were able to defeat 11 of them and delay or postpone or the progress of at least 5 of them. So I guess Nevada is one of the ones that got through their fingers and we were able to pass. But and I've seen some discussion boards about why the CRNAs would be advocating against. I see Dr. Harder chuckling over here. Why they would be advocating against allowing expansion of healthcare providers that would facilitate the shortage that we're experiencing. And it's funny, some of the people are pointing out that the arguments that they see that the CRNAs are using against allowing A's to be licensed in their states is exactly the argument that they were making against us when by us trying to have them retained under physician supervision, part of the care team, and not get, that it's all about the money and whatever the arguments are. So it's an ongoing argument that's there, but I think it's interesting to note that not only with all the efforts that the AANA is making with the title misappropriation, being doctors of doctor anesthesiologists, nurse anesthesiologists, and with other aspects of their striving and many of the things that we've talked about today about this sort of animosity that can develop between our practices. It's interesting, though, that in this case, there's an active effort to stop providers from being licensed that have been trained to do so. And and in my mind, it kind of sheds a lot of light on the motivation, perhaps. I just want to mention there's some resources available at the ASA website. They've made statements on the definition of the anesthesia care team and physician-led anesthesia care team. And one of the things I was pointing out, I was talking to Dr. Hart earlier, the AANA is making attempts, and apparently in a few states they've actually tried to allow CRNAs to medically direct anesthesiologist assistants as part of the care team, a care team being redefined. And so there's these sort of statements and support that the ASA is making in the behalf of our profession go a long way to helping lay boundaries and place boundaries and lay groundwork for definitive explanation and definitions that can be found regarding these different, what could be confusing to politicians with no medical experience. I just want to take just a moment and expound a little bit on some personal experience. I started in January working at the the VA in Las Vegas, and we have been receiving their student anesthesiologist assistants as their clinical rotations, and it's been my first experience with them, and I have been impressed with their knowledge and their ability to apply that knowledge. The ones we've since January that we've been having has either been in the first couple of months of their rotations, and so they're they're very green and new to this scenario. And the biggest difference I see in having worked, for instance, when I was at Beaumont and El Paso, I worked as part of the student CRNA program. We had a teaching program there for the Army. And a lot of these I don't want to say kids, they're not kids, but I seem like kids because I'm so old. But a lot of these, the anesthesiologist assistants are coming to us, and this, other than a few weeks of some part-time rotations, part of their didactic work, they're coming, they've been exposed clinically. When they're coming, this is like their very first immersion into an intensive care setting, right? And so there's a good and bad of that. And the good of that is, in my opinion, you have a clean slate. And their only motivation is to learn, and they want to gain the knowledge and ability to be able to extend safe care to these patients. And it's been fun working with them and sharing my knowledge and experience with them and helping them to gain that education. The downside is that they don't have that confidence and the clinical exposure that CRNAs have had that were in an ICU for years and having that interaction with doctors and patients. And so they start out with a lot less experience. And so we try and, you just have to take that into account, knowing that so much of what we do is hands-on and mentored care, and to go along with how to apply that book smart to the patient care that we need to extend. And so it's been enlightening, and I'm excited for the future in our country. But I would say to each of you, because most of you sitting here probably are coming from states that don't allow them, or may not even know one way or the other, and may not know that you're coming from one of the 11 states where there was a bill that ever got introduced that got defeated, right? So I would just encourage you, as from the discussions we've heard, to get involved, to try and find out if there's ways you can advocate for this healthcare professional that is emerging and coming onto the scene, I think, in a very strong way. Although they've been around for a while, but very limited in their geographically, I think as they expand across the country, they're going to be an important team player with us. And so I encourage us to reach out and advocate and do what we can to help with their success. That's all.
All right, thank you, Dr. Cleansmith. I could be wrong, but Dr. Harder, you may know this. I think in Bridgeport, University of Bridgeport, there's a AA program, but they can't get licensed in Connecticut, so they can be educated and then graduate and then not be able to practice. So it's kind of an odd situation. But I would love to see the AOCA partner with the Quad A and see ways we can help get them licensed in all states. So next up is Dr. Tanya Snell, who will be speaking on wanting to sunset your career in a small town, an introduction to clinical, professional, and organizational challenges facing rural anesthesia practices. Dr. Snell is originally from Moose Jaw, Saskatchewan, and is a general community-based anesthesiologist with professional experience in northern wintry states. Her current practice is in Cody, Wyoming, next door to Yellowstone National Park. She spent her career serving rural populations, working both in level 2 trauma hospitals and critical access facilities. She's a member of several committees for the AOCA. She's also an item writer for the AOBA longitudinal assessment exam, and an active member of Park County Search and Rescue, and director of the peer advocacy team. So please join me in welcoming Dr. Snell.
All right, the last diehards. Thank you guys so much. It's really tough to make it through a long day like this. I know a lot of people had to fly back home for work too, but thank you for coming by. I'll try and kind of cut this down a little bit because there's slides and things that we've already discussed with regarding to the advocacy. One thing I do want to start with, I just want to shout out a great big thanks to my partner, Dr. Bradlow. He's working 5 primary calls in a row straight so I can be here to share this with you. So, I have nothing to disclose. All of these pretty pictures are from where I live, so I'm spoiled that way. I just want to say that a lot of times when we talk about rural anesthesia, people they talk about wanting to sunset their career there. You know, maybe I'll cut back, I'll go to a small place, work there for about 10 years, see how that goes. And I just wanted to show you kind of what some of the realities are in this arena. So let's start with a story. There's lots of stories in here, and there's lots of gross pictures, and there's pretty pictures, so maybe it'll kind of keep you a little more awake. So you start with a 25-bed critical access hospital, and you add a blizzard, and you make it the middle of the night, and 99.9% of the time, some lady in labor is going to show up, right? It's kind of typical. This woman was in active labor. She was ruptured and she was dilated to 5 centimeters. She was a very petite woman. She's very tiny. She's been short of breath lately and her feet have been kind of swollen. And I'm called for an epidural. And I'm casually told, oh yeah, the patient had an ASD repair and has some residual pulmonary stenosis. I'm like, what? But she saw the MFM. I'm like, oh, great, great. And they had an echo done. Great, perfect, okay. And I get this echo, and it's the fetal echo. It's not mom's echo. So there's no maternal echo for this patient on file. So I at least try and find some pre-pregnancy echo, and they were able to do that for me, so that was spectacular. She had a normal ejection fraction, she had mild RV dilation, she had mild pulmonary stenosis, moderate pulmonary insufficiency, and she had severe dilation of the main pulmonary artery. It was 4.9 centimeters in diameter. Now, I'm not an expert in congenital cardiac pregnancies, right? I'm at a 25-bed critical access hospital. The patient is unknown to myself. She's also unknown to the obstetrician on call. We happen to have a locums cardiology guy this weekend. That's kind of fun. So we do a telemed conference call to Salt Lake, which was the closest MFM that was available at that time. Our regular MFM in Montana at the time had quit, so there was a bunch of changes there. So we'd called Salt Lake. And there also was an adult congenital cardiologist there that was talking to us. And so we're talking to him, we've got this lady, we explain the whole echo, I go through it very specifically, all the measurements. They're like, yep, okay, well we're ready to accept and we're gonna send our fixed wing to pick her up. We're like, oh no. There's no planes coming in, there's no planes going out, and there's no driving in and there's no driving out. We're calling you to see what we should do with her. Is it okay for her to labor? Should this be a primary C-section? What do you guys do at your facility? What should we be looking for? Can I put an epidural, a spinal? What am I supposed to be doing with her that's the safest? What do you normally do? And I hear silence. He goes, whoa, wow. Okay, well, we do let these patients labor here. It's okay to let her labor. But whatever you do, do not drop her pressure. And if she flips into any kind of tachycardia, it must be immediately controlled. You should call that locums cardiology guy. So it was like the sweatiest epidural I ever put in my life, right? Like you're like, oh, this is the one I'm gonna tap, the little tiny girl, and she's sitting there. But we did okay. So today, let's define rural anesthesia. Let's discuss some clinical challenges. Let's highlight professional and organizational issues. We'll review some legislative efforts to support rural practice, maybe brainstorm just a few more timely, maybe realistic supports, and review the good and how to prepare for rural practice if you do choose to do that. So what is rural anesthesia? Is it the population size? Is it how remote you are? Is it your resources? In some government literature, they consider anything under a budget of like $10 million a more rural kind of situation. So you'll find different definitions. It's pretty obvious, this 25-bed hospital in Cody, Wyoming, critical access, 6-bed ICU, which really functions like a step-down unit. We serve 4 counties and 14,000 square miles, about 42,000 people. Those are the services we have. That's pretty obvious. I think we all can agree that's rural. That's pretty rural anesthesia. If you need the map, this is Wyoming. We're in the top corner there of Wyoming in the northwest corner. We are right close to Yellowstone Park. We're kind of in this, what we call the basin area. We're kind of surrounded by rings of different mountain ranges. We're the 10th largest state, second lowest population density. We cover, our hospital is catchment for about 14,000 miles, which is greater than the size than the state of Maryland and about a third the size of Indiana. But let's look at this place. This is Minot, North Dakota, and I also worked there for a couple of years. 147 inpatient beds, level 2 trauma center, 25-bed ICU, 10-bed NICU, and it serves the whole northwest corner of North Dakota and the whole kind of a little bit of spillage into the top corner there of Montana. So our catchment there is about 30,000 miles in area, so larger than the whole state of Indiana and larger than Maine, about a 90,000 person catchment. But my argument is this person is practicing some rural anesthesia too. These patients are coming from far away. You often have problems with inpatient stay qualifying for that kind of stuff. You know, you have a 3-year-old tonsillectomy. If you send that 3-year-old tonsillectomy home out to a ranch 3.5, 4 hours away and she has a post-tonsillar bleed, that child could very easily be exsanguinated before she ever makes it back to any kind of medical care. So my point is, more of us do rural anesthesia than you anticipate, than you realize. Whether it's your facilities rural, where you live is rural, or our patients are coming from rural circumstances. I'm going to focus mostly on the critical access hospitals. It's an interesting cluster in the Midwest there of them. They're under 25 beds. They have a yearly average goal for inpatient stay is less than 96 hours. 24/7 emergency services. They're supposed to be 35 miles or further from the nearest hospital, or 15 miles if you're in mountainous or only have secondary roads. So here's my little hospital again, and we're doing some weird things. We're doing Chiari decompressions. We're doing multi-level A-lifts, total joints and super morbidly obese people. We have a new robot, yay, right? We're doing big robotic paraesophageal hernias and takedowns. We did a cephalic version attempt the other day on a 42-year-old G1P0. And then we have a couple in our county and area. We have some pediatric congenital patients that we see kind of regularly. One of the biggest things about rural anesthesia is that you are it. If the ED is having issues, they're calling you. If the hospitalist is having issues, they're calling you. If it's the OB, the surgeons, they're calling you. Anesthesia functions as the critical care, cardiac, neurology specialist in the area. And then there's all of the other little minor things, right? Scheduling, nursing, policy, staffing, billing, patient complaints, it all funnels to you. These two pictures are actually from patients of mine. This is a fracking accident. They were testing explosives and it exploded right in the gentleman's face. So this is the kind of stuff that we actually do get. Some of the clinical challenges, we have professional isolation. There's not a lot of other physicians to collaborate with and talk about and get their opinions. We have limited resources. Blood bank, my blood bank has 6 to 8 to 10 units at a time. Probably 4 of those are O-neg. The rest might be various mixes in there. A few units of frozen FFP, and that's it. We don't have any platelets or anything like that available. Lab, respiratory, radiology, all can have limited hours, especially at night. And then when we do order tests that may or may not get done, especially echo kind of tests, they take a while to get performed and take even longer to get read. We have had some improvement. We have a cardiologist now on staff, so that's helpful for that stuff during the day. Patients have complex medical issues. They're getting sicker, they're getting heavier, same as it is for you guys. And there's rare diseases that still pop up for us too. And it's interesting, like the patient's expectations is that our healthcare is homogenous throughout the country, right? They don't want to go to a bigger station or a bigger facility. They want to stay at home and be close to their own family and own members to have their healthcare performed. And so we do see pulmonary hypertension, altitude and COPD issues, sleep apnea, valvular disorder, obesity, all of that kind of stuff. Yearly, we end up doing some kind of surgical procedure in some pregnant patients too, pretty consistently. The clinical challenges, again, the clinical questions all funnel to you from the PAT clinic. You're the one making the decision and arguing with surgeons all of the time. And because major surgical and anesthetic complications are statistically rare and our volumes are lower, we don't see the complications. So it's very difficult to try and explain risk sometimes to the surgeons that you're dealing with. It's a constant battle. Not too long ago, a few days ago, I had the surgeon wanted to bring an 85-year-old paraesophageal robotic hernia repair. Her RSVP on echo was a low 40s, but she had had 5 ER visits in the last 6 months for syncope or near syncope. So, all of the bells are going off. And the surgeon says to me, well, 40 is just barely pulmonary hypertension, right? So you're it. You've got to help him figure that out. Rural trauma. These are things that have come from my particular facility. All the regulars. We see everything that you do. We tend to have a few more industrial type accidents from farm equipment, and we have rodeo injuries where I am. Burns, explosives from the oil fields. And then we actually have some bear maulings around us usually every year. Those get picked up, stabilized, and you're called to help do with that. And that's a footprint of a grizzly beside my boot there, so. Pediatrics. So we don't do a lot of pediatrics in that area. We do kind of well peds in general, tonsils and ear tubes and such. But I get called to do neonatal intubations when a baby's not doing well, unsuspected, the baby's delivered and there's an issue, I'll get called to do that. The particular infant that's kind of purple there, that poor baby I bagged for 8 hours waiting for the NICU team to come from Salt Lake City to pick up that baby. So we were bagging this baby and my assistant was doing some chest compressions every now and then to unload the right heart. The other infant here, I was asked to intubate him. He's got kind of a big heart and his sats are a little low. And he's got some funny vertebrae, which your ears should go up and you should go look at your film yourself. Because this is a Vader kid, right, who has all these kind of marbly looking vertebrae instead of the normal things. So you're not going to be extending that child's head too crazily. I wanted to mention suicide attempts. We've had recently, in the last 2 weeks, we had a suicide attempt in like a 10-year-old. And I want to say that some of those really traumatic things like that are really difficult to deal with in your smaller hospitals and smaller teams because I can't then shield whoever was involved in that care from pediatrics for a while or from work for a while because they're going back to shift right away or they're going to have to deal with the next kid right away. So it can be kind of traumatic and difficult for them. We're stuck, these are all photographs again from my area, weather photographs that keep us locked in, that keep us stuck with high acuity patients. We have a wind problem in Wyoming. Sometimes you can't fly in or drive out because of wind. And then in the spring runoff, we often get some of these road washouts, which is really problematic because some of these communities are locked in by one kind of main road in and out. So the one on the top was coming out to the main road that went to Idaho, which would have been the next level of care for the bottom corner of Wyoming. During COVID, we were stuck with a lot of high acuity patients, just like everybody was. This is kind of just a visual picture of all the different places we sent people to. For our acute coronary syndromes, we were sending them as far as Missoula. The Seattle and Mayo Clinic were our ECMO places that we sent a few patients to. But you can just see the logistics of moving people that far is really a big issue. So professional and organizational issues, meetings and committees, you will be on all of them, every single one, because there's only 2 of you. And this year I'm the director and next year you're the director, right? There's a lack of schedule flexibility, as my partner can attest to, who's working 5 days straight of call. The call requirements can be pretty burdensome. And then it's difficult to avoid toxic staff, or you might even have one of those persons on your department. You're at the same meetings, you're at the same facility, you know, you just can't get away and get some space sometimes, so that can be really difficult. We all know about reimbursement, it's falling. And so for us, specifically at a smaller hospitals, you know, we really have to negotiate for subsidy type contracts. To be able to pay to have the staff to cover things. And the hospitals sometimes are a little unreasonable. This is the actual block schedule set up at my hospital right now. It's just a couple things I want to point out. Monday, there's that red room. They want this 3rd red room for endoscopy, but only on the odd weeks. The green guy on Monday and Wednesday is the new robot room, and he's consistently overbooking till 7, 9, 11 p.m. And oh, and by the way, nobody wants to work Fridays. That's wide open if anybody wants to do something. And then on Wednesday at 7, not 6 before the other 2 ORs or anything, just 7 instead of 7:30 is elective C-section time. So how am I supposed to staff for that efficiently from a cost-efficient manner? You know, it's really difficult. And then there's several examples. I think that we have to have a pretty honest conversation with our surgeon colleagues that they are part of this problem too, right? There's examples of their demands breaking the anesthesia system for some of us. Elgin, Illinois, the surgeons wanted coverage past 7 p.m. Las Vegas, surgeons demanded increased evening and weekend coverage, which caused a lot of problems. For ourselves, it's this Monday day with the extra room. Like, how am I supposed to bring on a whole nother staff member that then doesn't have any work to do for the rest of the week? And then the anesthesia, it's not just us, it's nursing and the OR staff. They're already short, overworked. So the same people that are on call are working late. They're the same. The surgeon goes home and they're still cleaning equipment, wrapping equipment, and they're back at 5:30 in the morning. You know, it's really helping to generate that turnover in your ORs from all levels of staff. We have personally, you know, if you're working at a small place, you're pretty far usually from your family and friends. There's some social isolation, and then you some of the professional boundaries get a little sloppy, and I've seen people get in trouble, you know, just because it's a small town, small area, and you're kind of not keeping some of those professional boundaries where they should be. Travel distances and expenses. Our airports are rural, they have weird connections, it takes you forever to get anywhere. And for Cody, like, we're not even on a major interstate road, we're only on secondary highways. Shopping and entertainment limitations, school limitations. The weather extremes, there's a lot of weather tax that people have to pay when they live in different areas, in that you have to pay people to come and work in blizzard country, right? There's not too many of us that like it. And then the cost of living is often high. In Cody, our housing is 132% of the national average. In Wyoming in general, our healthcare premiums are 145% of the national average. So there's some cost to living small too. So recruitment can be extremely difficult. Most successful recruits, they have a very specific reason for wanting to be in that particular area or small town. They usually have family in the area, or they usually really have some very particular type of recreational activity they want to be close to. So a friend of mine moved here for ice climbing, and that happens to be me in the yellow, but you can see those little specks beside us, and that's actually the guys at the bottom. So it's pretty fun. But there's the idea that it's slower pace and less crime, lighter patient acuity, and call is less taxing. So let's take a look at some of that. We talked about why they're avoiding it. We'll kind of skip that just in the meaning of time. But the two most compelling incentives for physician rural retention are increased compensation for clinical and leadership duties. Remember all the meetings you were doing? You can't spend that much extra time asking people to do everything and not compensate them for that. And decreased hours or a more flexible schedule. We'll talk a bit about that too. We talked about market pressures. Our CMS is dropping. And if you look at Medicare over the last 20 years, we have decreased in 20% after adjusting for inflation, and it's 30% for reimbursement over the last 30 years once adjusted. And then you guys know, the payments are much less than what the private payers are, but the commercial payers are trying to follow suit. And in a small place like where we are, we don't have a lot of leverage against the healthcare companies, the insurers, because in our area we have Blue Cross Blue Shield. That's it. So they get to kind of demand and just set what they want as far as rates and reimbursement. And because we don't have the volumes with them, we don't have the bargaining power. We talk about market pressures in rural practice. This is Billings, Montana. It's 100 miles from where I live. It's a 15-minute flight. It's our main referral area. And there's two big hospitals in this system, but we're going to talk about Billings Clinic. Billings Clinic, sorry about that. It's a 336-bed level 1 trauma center. And they kind of had the standard post-COVID anesthesia crisis that we all faced, right? They were short-staffed, burned out, lost providers, couldn't recruit. And that private group went to Billings Clinic and asked for some stipend. And through that whole negotiations, which was painful, the hospital ended up walking away, and the group did. I'm not sure who walked away from whom, but they contracted USAP. And USAP had trouble fulfilling that contract, and they've only had a 1-year term with that. So the hospital is now trying to build and hire internal anesthesia team. Thing is, they need 30 anesthesiologists, and under their current model, they want 15 to 20 CRNAs. Their package is $150,000 more than I can offer in Cody, Wyoming. They have better health, better retirement, better benefits, because they're a large corporation. The call is a fraction of what I'm asking people to do 1 in 4, and they're doing 1 shift a week and 1 weekend shift every 6th week. And they're literally on the other side of the mountain range. Same set of mountains. They're on one side, we're on the other. So how am I supposed to compete against that? And my CEO wants to use the fair market value for the entire country when they're trying to recruit and obtain their own anesthesia. And I said, you're in a local market that you've got to be sensitive to. Some Intermountain West specifics. During COVID, everybody moved out there. California sold out. A bunch of people that were very wealthy sold out and moved in. So we had a huge increase in second homes and VRBO type home buyouts. So we had a lot of workers move just an hour away from the mountains, so we lost volumes there. We have aging surgeons, and then we have staff losses and are unable to recruit. So nothing that's unusual. If we look at the legislative support of rural anesthesia, there's the opt-out that we've all been talking about with CRNAs. The Resident Physician Shortage Act was an aim to fund additional residency programs. It's an amendment of the Social Security Act. The Resident Education Deferred Interest Act, interest-free deferment on student loans while you're in fellowship and internship. And then there's the, as we were talking about, the anesthesiologist assistant practice implementation by different states. Those ones were working to increase providers. If we look at incentivize rural practice, there's a Specialty Physicians Advancing Rural Care, the SPARK Act, which authorizes loan repayment programs to encourage specialty physicians in rural areas. And there's the Medicare Access to Rural Anesthesiology Act, which has been talked about quite a bit lately. And we'll take a look at that. And so that's a prior pass-through legislation which allows qualifying rural hospitals to use Medicare Part A to pay for AA and CRNA services. And so this amendment seeks to expand to allow those funds to be used for anesthesiologists. But there's some qualifications to qualify for that. You have to only employ one anesthesia provider, and you have to have fewer than 800 procedures a year. So, I have some questions about that, like what kind of cases are happening at this facility? What anesthesiologist is going to want to work at a facility and be the only provider on call in perpetuum? Right? It's like, what CRNA or AA is working by themselves somewhere without any assistance? So other than the principle of being equitable with regards to reimbursement monies, is this really going to be a clinically significant thing to help us increase rural anesthesia care? And then there's this great little website. If you look at govtrack.us, it's an independent government accountability site. It was started in 2004. It's got 3 part-time staffers. They follow legislation filings and status, and they do some original research regarding the different bills, and they follow the representatives' voting records. They receive no outside political or government funding, and you can subscribe and follow the specific bills that you're interested in. It tells you who sponsored the legislation, where it is in the process, and what its prognosis is. So I'll direct you to the top line, which is all House and Senate bills for 21 to 23. Only 11% of them made it through committee, and only 2% of them were enacted. And so then the other bills that we talked about are listed in that table, and you can see the various percentages of what's their likelihood of getting through committee and their likelihood of getting passed. And that's kind of depressing. Talked about opt-out states, nothing that we haven't talked about here. This is the time frame of when each state kind of chimed in on opt-out. One thing that I wanted to point out about opt-out states is that it doesn't matter what your state's legislation is. You as an individual facility can make your bylaws without the opt-out. So our particular critical access hospital has physician supervision or physician engagement with our CRNAs, even though Wyoming currently now is a opt-out state. So you don't have to follow suit with whatever the legislation is in your state. So the other question was, do opt-out laws even increase anesthesia services? And there's this nifty little study done by Eric Sun and al., and they looked at over 1 million Medicare claims data cases. They looked at total hips and total knees, so elective major cases, hip fractures and appies, so kind of urgent cases, and then some minor cases, scopes and cataracts. And they looked at your zip code as a proxy for, did these opt-out laws increase the chance that you would have your procedure done in a more close fashion, okay? They looked at before and after in opt-out states, and they compared them to non-opt-out states. And they did control for comorbidities and some zip code sizes. But they really found no increase in access. There was no change in the distance that people traveled for their surgeries. There was no change in the number who went outside of their home zip code for services. There was a small exception. There was a 2% reduction in those leaving their home zip code for total hip. However, 80% of those still left home for their total hips. So there was no change for the cataracts or the minor procedures either. There was no increase in anesthetic use within their facilities that they came from, within their zip code. So if it didn't increase access, why? Well, the studies don't take into account resource limitations to perform surgeries as a whole, right? There's also nursing shortages. There's also surgeon shortages. There's also equipment limitations. You know, we have increasing demand and an increasing aging population which has more comorbidities. They're still not appropriate for that small facility, even if you have somebody there to be able to perform the anesthetic. So while we're short on anesthesiologists, the market's also short on CRNAs, and that market's expensive, which you all know. You guys understand the factors contributing to shortages. Just one point, right? There's always this kind of misnomer. We're out there saying, and I was guilty of it too, that there hasn't been an increase in residency slots in decades. Well, there actually has, okay? When we look at it, there's been about a 60% increase in anesthesia positions from 2004 to 2023. But the question really is that enough? So let's look at aging. Let's do some math. I know it's late in the day for math, but we'll just whip through it. You have about 53,000 anesthesiologists. Half of us are older than 55 years old. Over the next 10 years, 20 to 25,000 of us may retire or reduce our workloads. So if we look at the 2,000 graduates that we now have a year, over 10 years, that's 20,000, but 20,000 of us are going to retire in the next 10 years. So it's kind of a net zero game there. If we look at CRNAs, they're the same. They're half or over 50. They have about 2,400 new graduates a year. They have much more varied work schedules too. But even let's just take the best case scenario. You've got 2,400 graduates for 10 years, 24,000, but they still are going to lose probably at least 20,000 retirees over 10 years. So they have little effective growth in their workforce too. We talked about the anesthesia assistants. There's only 3,000 of them, 3,200 of them, and they have about 325 graduates a year. So they're not going to make the biggest impact out there. When we look at national staffing companies, sorry, USAP, North Star, Napa, you know, there's some ownership by private equity firms. There's some data that suggests they increase anesthesia costs and charges. They tend to underbid some local private groups and obtain facility staffing contracts. They're anywhere from helpers, right? Hey, they've helped us out in a lot of different places. They also can be kind of mercenary, right? They're not typically invested in your medical community. They can be very transactional, and some of the skim percentages, depending on the company you're working with, can be shocking. You're making $350 an hour working in the OR, and there's some amazing invisible ghost in the corner making $150 for every hour you're working. So it is illogical to think that any staffing company, any locums contract can fully cover our shortages. We all have our hands in the same pot, right? There's only so many of us. So like this IV says, doesn't draw back, but flushes great. It's right through. There's the elephant in the room, the call. We're going to ignore him for a minute. So we have to focus on some staffing solutions that we can impact, right? We got to keep those older workers around. We got to really seriously consider duty adjustments for aging workers. We don't do call well as we age, so let's be creative about how we change their position as they go forward and not lose them early. We need to maximize staffing and schedule flexibility. If the facility gives you 5 FTEs, if I want 2 of those FTEs to be 4 part-time guys, it's none of their business. There's some, tweaking you have to do with benefits, but we just need to be creative. And some people are going to need a part-time position for a while, but you got to give them the opportunity too to flex back into full-time work. There's just many different phases of our lives that we need to accommodate. And then the worst thing you can do for any anesthesia group is have somebody outside of our department tell us how to work or how to schedule, right? That's kind of, you really got to maintain control of that. That guy comes up again, the elephant in the room, the call guy. We're going to ignore him again. We also have to have administrations that are really committed to wellness, right? You can't force people to be on call and not give them a call room. You can't, people notice how you're treated, and that either helps them stay or makes them leave from a facility. We have to have a serious focus on OR management too, with a goal to maximize efficiency. Do you really need 3 ORs open when your utilization is 50%? Why are we staffing 3 730 rooms for 1 or 2 cases each, when all of those could be stacked in one room and be done by noon? Improving efficiency will help to retain us. It'll also help to retain your other staff. Okay, the elephant comes back again, the call guy. We're gonna have to deal with him eventually, right? So call is an inherent part of our profession, right? Illnesses, emergencies, injuries, they don't happen on a time schedule, but that's not what irritates us, right? We're not bothered by the injury or the sickness in the middle of the night. We're bothered by the elective induction that starts at 8 p.m. that'll almost always guarantee my epidural needs to come in at 2 a.m. And I'm a 25-bed critical access hospital, and I'm back to work in the ORs at 6. So those are the things that your facility has got to kind of help rein in if you're going to make this more palatable to people. We have to shut down too the robot guy. Remember him? Yeah. We have to kind of curtail his thing. We have to just make this call as humane as possible and don't abuse staff with non-emergencies. Don't allow elective cases to book over. And place as many as you can on the call rotation. One thing that I've thought about a lot is a future solution that maybe is out of the hands of the federal government. We all feel a little tied to graduate medical education funding in our hospitals, so why don't we do it like some of the hospitals do with nurses? They pay their staff, they provide the training with a work requirement. And it's a possibility that we just have to start thinking about other ways to do it that are more flexible without waiting for the government to sort it out for us. Reimbursement, we talked about that already. I'm not going to go too much over that anymore. But it requires the financial support of the institutions that you're contracted with, right, to be able to survive. When you look at critical access hospitals, they already are getting a subsidy from the government to be that critical access hospital. There's a drive to have private insurers do that same kind of subsidies for the critical access care for their patients, kind of an alternative payment method. So instead of a pure fee for service, the private insurer would also pay a flat rate with then some minor adjustments for fee for service afterwards. Because the cost to deliver any service in a critical access hospital is huge compared to what it is at a big facility. The problem is that all of those extra supportive funds go to the facility itself, and you really have to have a serious conversation, and it can be very difficult to get those funds distributed out of the hands of the facility to the specialists that need it. This is my own private group. This is our RVUs, monthly RVUs for our hospital facility over the last few years. And if there's one thing I can say when you're in these kind of negotiations is that you guys have got to keep the data and you've got to keep looking at it. So 2015, 2016, that's kind of an anomaly. We had a really aggressive surgeon that was doing a lot of stuff there. And that's one thing for small hospitals. Surgeons can make a big difference, a particular surgeon that's around, up or down. But then you see we have 3 years of kind of where we expect to be as far as our RVU production. COVID hits, and then you notice we don't have any recovery on that. So we've stayed stagnant. So in watching this trend closely, we realized we were unable to recruit based upon what our reimbursement was, and that we were looking at financial insolvency. So we negotiated a stipend plus an RVU deficit model with our hospital. We took a pre-COVID 3-year average RVU production, which was $2,600 a month, and we used an average blended rate based on our payers for a RVU payment of about $53. And we use this deficit model. We calculate every month what our RVU deficit is, and we charge the hospital that as an extra bill above and beyond their stipend. It worked. I think it would have worked better had we done it a year earlier and maybe asked for a little bit more based on our local market costs. Probably push that RVU blended unit to about 60 instead. Would have been better for us, but I think we did this a little too late. The reimbursement issues are tied to surgeon productivity. Like I said, we have aging surgeons. There's a lot of times they're just looking to fill those spots with warm bodies, and they're not really supporting them well, so the surgeon turnover can be high. I had a friend who always used to say, she was so tired all the time, she's like, if you're an ASA 2.5 or lower, you're hired, right? But there's a lot of benefits to rural practice. There's an increased sense of mission. You have a lot of stronger relationships with your team. You have amazing lifestyle opportunities, a lot of practice autonomy, plenty of leadership opportunities, if you like that. And there's access to some incentive programs. These are some of the benefits of rural practice. You get to see some amazing places and do some amazing things. I'm just going to skip that. And more benefits, more benefits, more benefits. This is, you get a bit more community involvement in rural places, some access to different things that you probably wouldn't get in a bigger city. How to be successful starts in residency. Heterogeneous high volume training, build a large toolkit, try and figure out every little trick and tool you can and put it in your pocket because you're going to need it. Post-residency experience is ideal if you can get 5 to 10 years at a bigger institution. It's just time to be around other people and learn from them. And you have access, you'll run across more of those zebras, so when you see them when you're by yourself, you'll know what to do. Know your resources and check on them frequently. You don't want to be in the middle of a C-section and use all the blood products in your hospital and call for cryo and be told that they don't keep it anymore because nobody uses it. So then you're doing a hysterectomy on an 18-year-old. You don't want to be in that position, so know what you have and what's going on. Refresh yourself with the things you don't often do. Don't be shy. You're going to have to look some things up. There's no specialist there to do that. And become a good researcher. Your surgeons aren't going to trust you all the time when you say something is unsafe. You're going to have to produce the data for them and share it with them in a meaningful way. Communicate a lot, and that's nothing specific to rural healthcare. And go and talk to people in person. It makes a big difference. The other thing I wanted to say is that you've got to have empathy and lift the people up around you and praise the good and help correct the bad. You have to be kind. Your nurses that are struggling to get a pediatric IV, they were trained at your local community college, they have a 2-year degree, and they haven't seen much pediatric care. So help them and don't be judgmental, and it's going to go a long way for helping you be successful in those areas. That's all I have for you, so any questions?
Thank you. All right, thank you, Dr. Snow. We are running a little bit over time, but I'm going to open this up for a couple of quick questions if anybody from the audience has any questions. I just have one thing I wanted to ask David, and anybody in the audience can also chime in here. Regarding AAs coming on staff, if you have your hospital with just physicians and CRNAs, and now How does that work politically when you want to introduce AAs? I'm sure there's a lot of um, grinding of teeth and a lot of angst from
I
politically from the leaders in the hospital.
Okay. I know for a few months that was the discussion was how do we address that potential conflict that there might be. Initially, the thought was, that we would probably just keep them at one particular hospital and where we knew they would be welcomed and perhaps have that opportunity to adjust and adapt. We also approached our CRNA committee and let them know this was coming and asked them to kind of proactively educate themselves and prepare the kind of a change in culture so that there wouldn't be any hopefully any conflicts occur. But and it's been 2 weeks, so I don't know, haven't heard anything. I haven't worked with them there personally. I don't know, but I spoke with some of the CRNAs, and they all several of them had worked with them in different locations, and others said they were open to the idea. Again, I think this goes back to that idea of we talk about CRNAs, and I think we should kind of try and change our vocabulary and talk about the AANA, because as we know, 100% of the CRNAs do not agree. In fact, the CRNAs at the VA I'm working at said that if the VA goes through with this not eliminating physician-led care team, that they don't want to work at the VA. They don't want that. And that's a common sentiment I hear amongst them, that they've got a good thing and they don't want to lose it, but there is a militant fraction within that AANA that's very aggressive, and so.
All right, thank you. Any other? Yes.
I've got a quick question about the anesthesiology assistants.
Yes.
I know the PAs have got a doctorate, they call it a Doctor of Medical Science. Is that applied to the AAs, and are they being pushed towards it the way CRNAs are pushing towards their doctorate?
Can you restate that? I didn't quite hear that.
Our local university has got a Doctor of Medical Science,
Oh,
which there is a doctorate for PAs, and I'm wondering if the AAs are also using that because they resemble the PA in the operating room. They're pushing themselves towards a doctorate level degree also.
yeah. Is that like an analog to analogous PAs getting a doctorate of medical?
Yeah, the A's, again, I've only worked with a few of them and as students, and it's a very different mentality and a very different mindset, and like I said, I think in a lot of ways we get you get somebody who hasn't been in an environment. So, some of that indoctrination or radicalization, whatever you want to call it, some of that starts in their education, right? And a lot of the programs sort of encourage that. I haven't seen it. The limited experience I have.
We haven't seen
No,
it yet.
I mean, our
It's
group is
coming.
our group is a mixed group. Our private small group is physicians and CRNAs, and we have a great team. And we work as a team. And I tell you what, my CRNAs are not going to want to bag that baby for 8 hours, right? Like they know what they want help with, and I think it's being respectful back and forth though too, right? Giving them some practice autonomy so they can feel a worthwhile part of the team and not like they're being told what to do all the time or micromanaged down to what size syringe they're drawing things up in. And I think it's just respectful then. It's a respectful relationship. And I think if we continue to build that, it'll work out better, because we can't fill the positions with physicians. We just can't. We're going to have to make those models work. The problem is we don't teach residents to be leaders or to be managers, right? How many of you took a management class in residency? 0. You all were working in a linear fashion, doing one case after another, right? You never managed 4 rooms. You never managed 4 people. So then I have some small, like tiny physician, female physician who looks like she's 12 come out and tell my 30 years in practice CRNA guy what to do in minutia. It doesn't go well. And we need to help train our residents better too for that kind of practice.
All right. Well, please join me in thanking our speakers, Dr. Tanya Snell and David Klinsmann.